Week 5, it's probably my favorite week. I love cardiac, and I know most of you are scared to death of it. So I'm going to try to make that simple for you. And then it's respiratory. And remember, if you don't breathe, nothing else matters. So your lungs are a very, very important subject. They put them together because they work together, but they're two big topics. Just to let you know before we start, respiratory is always harder hit than cardiac. Always, because no breathing, nothing else matters. All right. So that's what we'll be doing today. I have a Kahoot for each one. So it's respiratory Kahoot, cardiac, and a Kahoot. If we have time, I might be going over some math questions in the end, the tricky ones. And even the ones that you might see on community type thing, because I know some of their math questions that they do get. I work hand in hand with that group also. Discussion question 4 is due this week. I don't know if this was the class or not, but the dates were wrong. So some of you didn't get it in by Wednesday. I'm not going to take off points because I didn't have a date down right. So you don't worry about any of that. If I made a mistake, I'm going to take ownership of it and I'm not going to make you pay for it. So don't worry about that. And then you have your first case study, your sim chart. And next week, I want to tell you to tell me what is your feelings on them. I actually like them, but you tell me your feelings because they are new, and I can help maybe another students by what your opinions are. Right? Okay. Anything else? Any questions? Next week is our starting for our exam reviews again. So I'll be doing mine again at Thursday at 4 o'clock. Yes, it's going to be posted just like I did last time. You will be getting all your information tonight at midnight, all of it. So you'll be getting study guides, you'll get your Kahoots, you'll be getting your PowerPoint, which is a study guide, the dosage calc. So everything is there for you. Anybody who was below an 80, please meet with me before exam 2. I don't want you going to exam 3 not knowing what's going on, and I can help you, but you've got to ask, all right? So you ask me, I'll work with you. And let's go. So respiratory system, the respiratory system, you don't realize it, but it starts with the nose and the breathing and the air in and all the way down into the lungs. So it's nose and ears and oral pharynx, all of that is part of your respiratory system. The upper airway is that upper stuff, right? And the lower stuff would be your pneumonias, or even asthma is a lower respiratory. And we'll get into that and the reasons why, etc. Now, upper respiratory infections, probably the most common of all things in children. Now, for me and you, respiratory syncytial virus is a common cold. But as you get younger, it becomes more of an illness that's harder to treat. And the reason is infants, when they're born, just learn how to suck, swallow, and breathe. And infants breathe through their nose, obligatory nose breathers. So, what does RSV do? It puts a lot of mucus and secretions in the oral pharynx, right? Infants don't know how to blow it out. It sticks there. So they're trying to suck, swallow, and breathe. They're gagging, choking, retracting. They're tiring out. They're not eating. And it's all because of this nasal mucus and a low grade temperature. So we're going to go into that later on. We're going to be giving something for those immunosuppressed children not to get it. Many upper respiratories are viruses. That's the big thing. And then the other one, and why we have an immunization for it, is the Haemophilus influenza. It's just one that causes a bad viral upper respiratory. Now, infants, when they're born, they get mommy's antigens, their antibodies, and they're protected somewhat at birth from bad diseases. But like all blood cells, any cells of the body, eventually they die off. So about 3 months, 3 to 6 months, that immune system is going away slowly, slowly. And now this infant is more apt and more going to get infections. Usually viral infections is what they usually get at first. And that's normal. Why do you think we give immunizations at 2, 4, 6 months? And we load them up like crazy. Did you see the list of the amount of immunizations? And if you've had children, you know it is a lot, 2, 4, 6 months. It's because those are the big, big, bad diseases that can really cause havoc in a young infant, and it could cause them to die. So we want to prevent them from getting it with these immunizations. Now, along with immunizations, how do we make our immune system? And it's by getting the disease, right? And then our own body builds up a defense against it. And eventually, we're not going to get that disease, or it's going to be minor as compared to many other children. Now, when you're a toddler, you're a preschooler, what do you do all day long? You play, don't you? How do they play? Swapping spit all day long, from toy from one mouth to toy to another mouth, toy to another mouth. So they're swapping germs all day long. And you're like, well, we need to stop that. Well, they also need to get the diseases to make the body get the immune system to prevent it from when they finally get into school and they need to be in school to learn, right? So toddlers, preschoolers are the biggest rate of infections. Have you ever heard a mother coming in? I did in the emergency room. It's like, I'm here every week now that I put my child in daycare. And the reason is everything's in the mouth. They explore in the mouth, and that's where all the germs go. Now, as we get older, now we're pretty well covered by a lot of the viruses that are out there. So it becomes more with bacterias, your mycoplasmas, your strep, your staph, and those sort of things. And then obviously, we get increased immunity with age, because if we get it, we're getting the immunity. We get it again, now we built that even stronger and stronger. Now, otitis media is part of the upper airway. It's connected to the oropharynx. Now, have you heard about areas of least resistance to most resistance and where we're going to shunt to? Well, you've got all this mucus, right? These infants, these upper respiratories, usually where it starts. They're full of all this mucus. Well, this mucus has to go somewhere. So these ears on these children they're short, wide open, and they are ready for mucus to pile up in there. It has to go somewhere, so they're trying to get rid of it. So it goes into the ears, and it goes up into the middle ear. Now, mucus in your nose always has staph, always. So when it gets to the ear with that extra pressure, it is a staph infection, and you need to give antibiotics. Now, you get an infant, child, toddler, preschooler, school age kid in complaining of an earache. And let me tell you, they hurt. What's going to be your priority care on that child? Otitis media, what's your priority nursing care?
Relieve the discomfort.
Yes, 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 yes. Number one, pain control. Because you could say, all right, but it's staph, it's an infection, but it's going to take 24, 36 hours for that antibiotic to kick in to relieve the discomfort of the pain. Very good. Number one, priority, ear infection, pain control. Good job, Yvonne. So a kid who's sick, what do they look like? I think the easiest way to tell is when they don't want to eat or drink and they don't want to play and they're just sitting there, or they're taking a nap in the middle of the day, and that's like totally unusual, right? You could see all of these symptoms. And again, all children, when they don't feel well, they stop eating. Yeah, they stop drinking. Adults, it doesn't matter if we're sick, if we're hungry, we're going to eat. We want to drink, we're going to drink. It's just what we do. Kids just don't. They somehow they know better. So our goal in upper respiratory infections, well, we want them to breathe easier. How are they going to breathe easier? What are some things we can do? Well, aerosols, suctioning, What about simple old positioning, elevating the head of the bed, or calming them down? Respiratory, they're anxious, right? It gets to the point of restlessness and hypoxemia, right? So, what are we going to do? Well, how about anything that we can do to calm them down? Put them in mom's lap, having them sitting up, distracting them, TV, iPad, cards, crayons, anything that we could do to calm them. It's going to promote good respiratory effort because they're not scared and anxious anymore. So then they're going to be able to rest. Now, spreading the preventing the spread of infection, I think it's pretty neat how kids, I know my grandson, when he came out of kindergarten, was coming home and coughing in his elbow, and he never did that before. And it's taught very, very quickly to prevent that. And of course, hand washing is a big thing. Now, why do we reduce the temperature? Why do you think we should take the temperature and medicate for it? Do we need to? Why don't we need to?
Because the body's trying to fight whatever the kid has picked up.
Yes, it is, absolutely. But one of the misnomers or falseness that people think is that a fever is going to cause seizures, right? Because we heard of febrile seizures. So we sort of put high fever into that class. It's completely different. I have had fevers on children, 106.5 axillary, no seizures. Okay. Usually, when they finally have a fever, you say, okay, you're safe now because you have a fever. And what do I mean by that? Well, the one type of fever that creates that seizures and all of that, concern is when you have no fever. 20 minutes later, you have 101. So the rate of rise was quick. So that temperature went from 0 to 100, quickly, and the brain went snap, seizures, and that's a febrile seizure. Usually, febrile seizures are 6 months to 6 years old, and they usually will grow out of them. And they're actually pretty hard to control because they get up there so quick. Okay, so you have the normal kid. They have a temperature. Why would I medicate them? Because I'm going to medicate them. And the reason is, did you ever see a child with a fever and then give them something for the fever, a good dose of the proper amount? Half an hour later, what does that child look like? They're up, they're moving, they're playing, they're drinking, they're eating. What is the care for any viral management? Symptomatic. What does that mean? Fluids, antipyretics, rest. Now, if I'm not drinking, that fever, I'm getting extra dehydrated, which is very dangerous in children. I'm not drinking because of the fever. Put the fever down with, antipyretics, and then they'll be able to drink. And that's what we want to do. Now, infectious mononucleosis, it's a kissing disease, right? It's not a big deal. Well, it's a herpes like Epstein-Barr, and it's a virus. So, no antibiotics here. So, again, symptomatic care. Viral care is symptomatic. Fluids, antipyretics, rest. All right. What is mono? Mono is a kid who comes in initially complaining of sore throat and flu-like symptoms. But they also have swollen lymph nodes in the neck, the arm, and many times their spleen or liver, or both. And you might see a rash, you might not on them. Now, you go into the doctor, and they say, okay, let's do a strep test of the throat and let's do a culture to be sure everything's negative. So we send the child home on symptomatic care, fluids, antipyretics, and rest. Well, they come back 3 days later, they're still sick, still have a fever, and they still feel horrible. So the doctor says, well, I don't know, but let's stick you on an antibiotic. And this is actually what happens. This is really the routine these kids go through. So then by the weekend, they're coming to me in the emergency room. complaining of sore throat, fever, flu-like symptoms, on antibiotics, nothing's working. So what do you think the tests are going to be on this child? Well, this child has mono. Well, it'll end up they have mono, but right now they have a sore throat and they're on antibiotics. So we need to find out what's going on in the body. So let's do a CBC. Why do we do a CBC on this child? What can a CBC show you when you're worried about a child who has a fever?
Infection,
Yeah.
Right. Is
white
it
blood
viral
cells.
or is it bacteria? So if the white blood cells are elevated, okay, it's a bacteria. Good. Put them on the antibiotic, we're cool. Well, this kid's normal white blood cells. It's a virus again, right? But we're also going to do something called a mono spot test, and it's going to come back positive. Now, I had a little boy, he was 8 or 9 years old, came in with his father on a Saturday morning. That story I just told you was actually his story, like many other ones that I've heard that's had mono. So they come in, we do CBC, mono spot test positive. The doctor gives them very strict discharge instructions, which are restrict all exercise for first 3 weeks until they're cleared by their pediatrician. No PE in school, and avoid all contact sports because the liver or the spleen, if they are enlarged, it's like a big balloon ready to pop. So if they get it hit hard, it's going to burst, and that's going to be the end of the child. So the doctor told them all of these things. I went in, told them all these things, and I gave a written instruction. So they had 1, 2, 3 times we were teaching this child and this father. 1 week later, I'm the primary trauma nurse on duty, which means any helicopter comes in, I'm the one that's in charge of the charting and managing and all of those things. It's my patient coming in. Well, we get a call. 9-year-old boy in the Everglades on ATV fell off. Came in. This was my boy. He came in dead on arrival. He popped his spleen when he fell off the ATV. So why do I tell you this story? Whenever you have a child, or if you ever work in pediatrics and you've got somebody with mono, really stress the importance of protecting that abdomen because it does happen, and it did happen to me, and I will remember that little boy for a long time. Okay, bronchitis. This is probably the most irritating of all the respiratory things. Usually there's no fever here. Usually it is at night when you want to sleep, this dry, hacking cough that's non-productive. That gets worse at night and you're trying to sleep and you can't. And you cough so much your ribs hurt, okay? That is bronchitis. It's also known as tracheal bronchitis. It's trachea and the bronchus. It's that area there that gets all inflamed that causes this cough. So how do we treat this? Well, you can do analgesics, probably that chest pain from all that cough can hurt. I mean, if you have a low-grade fever, but usually not. But cool humidity. Children and humidity, many of the times, there is what we call these tents, these humidity tents, and the problem with it is inside those tents the kids feel like they're being separated from their mother. Sometimes I'll let the parent get in the tent with them, or how about if they sit in the mother's arms and they can blow just that cool steam in their face, which is getting what they need, and they're relaxed, they're comfortable. It's respiratory, right? Relaxed, they're comfortable, they're breathing in the steam, it can help. The other thing we do is we give cough suppressants, all right? And it's just to help them sleep. Usually one with a little bit of codeine in it works the best, but I know today it's very hard to get codeine. They just don't produce it anymore, I guess from all the abuse out there. Now bronchitis is not croup, all right? They're different. Croup is the larynx up here, up top. And what happens is it narrows and it causes this unbelievably distinct sound of a seal barking. It is loud. You could hear it in a whole grocery store if a child's barking with croup. It's just that distinctive, okay? So the thing about croup, again, it's another virus that's going on here. That's that H influenza guy again. That's why I keep mentioning it, because it's really for the upper respiratories. That's why we give that inoculation, okay? But when the croup, we don't treat it, they keep barking. What happens? We end up with acute epiglottitis. Now, with croup, you can see this picture. I just recently found this picture. I think it really shows it, how it gets really narrowed in there. And of course, it's usually upper respiratory infection that's caused the cough and irritation that has caused it. Now, do you see it's narrowed in the upper airway? What do you think about the air going in? Do you think they can get air in easily? It's narrowed. So inspiratory stridor. I almost inspiratory stridor. Me, hold on. Oh, excuse me. Okay. So, croup, epiglottitis, anything upper airway, air can't get in. It's swollen. It can't get in. Once it goes down, it can come out really easily. That's not a problem. Because you are working so hard to breathe in, you're going to see the retractions, okay? And we know if we let this continue and continue, you know what's going to happen? We're going to be in respiratory distress. Now, croup left now becomes epiglottitis. Epiglottitis is a true and real medical emergency. Let me tell you why. What is an epiglottis? It's that leaf-like structure that covers the trachea when you eat or drink, so food or liquid don't go into your lungs. It goes down your esophagus. So this epiglottis is covering the trachea and not letting air get in. Can you imagine? It's like being underwater and you can't breathe because nothing's going in there. So think about this. This is a child who can't breathe. So this is going to be crazy. This kid's going to be restless, agitated. So this kid, number one, calm him down. Put him in mom's lap. Let him sit on the floor, wherever he wants to sit. If it's comfortable, you can work with him. That's what you need to do. Don't do anything to upset the child. You're going to see a child that can't swallow their own secretions. So it's drooling. Another thing, if they try to talk, oh, is what you hear because it's so swollen. That's basically what you hear. Okay. And the other thing, it's like the 90-year-old COPD lady who's in that tripod position trying to find a position that's upright to be able to breathe. I think it's like trying to find where's that little airway hole that I maybe can get some air in me. So you're moving around trying to find it. So, what do you think our goal is? It's respiratory, right? We got to get an airway. How are we getting an airway? Our airway is completely covered with the epiglottis. This is when you get the assistant, the secretary, whoever, go get the intubation cart and the trach tray. Get it in my room quick, and you just go in with the patient. Let somebody get that tray for you. Priority, priority. Because if you need to intubate or you need to do a trach, you need to do it quickly because these kids go down really quick. So, what do you think the treatment is? Again, this kid is restless, hypoxic, he's scared. He's like drowning. He has no air going in there. So we got to maintain the airway. Again, positioning, calming them down will always be number one. Okay. Then, if this goes on for a while, then you worry about hydration orally or intubation or excuse me, IV. We're not going to give a kid who can't breathe anything orally. Sorry, it don't work. You either breathe or you drink. So if it gets to the point where they need fluids, it's going to be an IV. Another thing, just like croup, the nebulized mist with a little bit of oxygen. And that little bit of oxygen just makes it a little bit easier to breathe. And that's why they do it. And then the two things that we give for this swollen epiglottis on top of that, trachea or croup with that narrowed airway and inspiratory, I can't get air in, we're going to give epi. And we could give it in an aerosol, a little racemic epi aerosol. And then we're going to be given steroids, usually intravenously, because they work quickest. Okay? So RSV, we talked about it already, right? RSV is also known as bronchiolitis. You're going to hear those names used interchangeably. It's the same thing. Bronchiolitis is RSV. It is most of a concern when infants are less than a year old. That's when the RSV that we say, okay, you were born with a cardiac disease, or you were born premature and you already have, damaged lungs, or you have cystic fibrosis, or you have that you need not to get this disease because swallowing, breathing is a lot of work. And we don't want to overtax the child who's already working hard with something else going on. So we give something called Synagist or palvizumab. You need to know this name. Synagist or palvizumab. And it's given monthly, only the first year of life from winter to early spring. And in Miami, I don't know what winter to early spring is. So usually it's all year long. They'll be giving it because what they're trying to do is help with the changing of weather. That actually does stimulate. When you're thinking about it, from winter to early spring, you go from getting cold to getting warm, and that's that change of weather thing. Okay, tonsillectomy, adenoidectomy, probably the most common of all of the surgeries on children, right? Ear tubes, DNA. Sometimes they do them all together. And it's because all the mucus in here, usually there's like obstruction, airway things, and then the ears, we usually will just put them together with one surgery. Now, these surgeries are usually done as an outpatient. They come in, get surgery, and go home. So most of the teaching that we do as nurses will be post-operative care. So think about what tonsillectomy or adenoidectomy, what does the surgery do? So you got those big things in the back of your throat. They cut them off with a scalpel and they bleed like crazy. So they cauterize them. So the area is cut, it's cauterized, the bleeding stops. Now there's big scabs in the back of your throat. Okay. Because of that, no irritating or seasoned foods because it's going to burn, it's going to hurt, and it might make you go because of that coughing. And that clearing throat coughing can also make this back of the throat start bleeding. No coughing, clearing throat, nothing in the mouth for tonsils, nothing in the mouth for epiglottitis, nothing in the mouth for croup, anything upper airway, nothing in the mouth. You don't want to increase swelling. Now, we can use analgesics for pain. Today, we only use acetaminophen. It seems to be just good enough for them. Years ago, we used to use something else, but with a little bit of codeine, but they actually found the kids were getting overdosed on it. So we stopped giving that and just do acetaminophen. Now, another thing we can use is an ice collar. Now, young kids aren't going to use that. They don't like it. They don't want something on them. They just get it away. But older children, you put it on, it does. The ice does help with pain. Now, chewing gum. And why do I say chewing gum? Ever go up in an airplane and your ears pop? And they always tell you to chew gum or open your mouth and try to yawn to pop your ears. Well, post-DNA surgery on older kids causes their ears to plug up and get pain in them. So chewing gum is like going up in the airplane and opening your mouth and popping your ears. We're doing the same thing for the TNA. Now, post TNA, they usually do really well. Now, your mouth is going to smell. There's a scab in the back of your throat. But if it goes on over 10 days of fever and whatnot, that's way too long. And it really needs to be investigated. Okay. And then either persistent earaches, et cetera, et cetera. Now, they usually say activity within 1 to 2 weeks. Now, I had a little girl, I'm going to tell you another story. Another little girl, I think she was 7, came into the ER. She had just gone to the ENT post TNA visit. She was going home in the car and vomited, and clots of blood came out. Rushed her over to me. I'm the triage nurse at the hospital, and she tends to vomit big clots of blood. I look at her, she's getting pale. She's starting to get a little bit, drowsy. And I went, okay, picked her up, and we rushed her into the trauma room. Got the doctor, got somebody to help me, started an IV. This 7-year-old girl got 1,000 mLs of normal saline to get her heart rate and blood pressure back up. Her heart rate was 160. It should be what, 90, 80? That'd be normal. So she was really going hypovolemic, and her blood pressure was 70/40. So gave her the liter of fluid, brought her up to the OR. They recauterized the area, and she went home and she did fine as far as I know. But again, tonsillectomy is no big deal, but they can be. Okay, pneumonia. Pneumonia is many different ways. Could be inhaled, or it could just be a consolidation type pneumonia. We have viral pneumonias and we have bacterial pneumonias. So what's the difference between bacterial pneumonia, viral pneumonia, and the treatment? What is the difference? Bacterial pneumonia, you're going to give antibiotics. Viral pneumonia, supportive care, fluids, antipyretics, rest. Okay, I think I'm getting the point across. So all sorts of pneumonias, and thank goodness that pneumococcal vaccine, because that is a really difficult pneumonia to take care of. All right, another sort of aspiration. It used to be my favorite thing to do. We used to have powder in the newborn ICUs when I first started. I used to love the smell, love to powder up my infants, and come to find out I was sprinkling powder in the air and they were inhaling it, and I could have hurt some lungs. And it's just, we didn't know. As we know, nursing evolves and it gets better and better as we go. And I could tell you so many stories of changes in the last 50 years that I've seen. It's unbelievable. So, no powders because of the air and the inhaling it. Another type of aspiration is feeding. Now, infants, when they're fed, they shouldn't be overfed. They need to be well burped, and they should be sitting up after they eat. That helps prevent that reflux and that aspiration, okay? Another thing is not to have any sort of, cleaning supplies. I mean, bleach and going into the bathroom and putting all those chemicals. Don't bring the baby in there. Again, just like we can get these aspiration pneumonias from chemicals, oh, babies do too. And actually, they're harder to take care of. So children, what do? Everything in their mouth, right? So they're gonna put stuff. And one of the things they love to put in their mouth and swallow is coins. Now, what do you think was the coin they liked to swallow the most? The dime, the nickel, the penny, or the quarter? It's the quarter. They like the bigger thing. They think it's more money. Well, in this one case, it just happens to be bigger, but they like the big coin. And this picture is classic, stuck right there between the clavicles, stuck. Now, these children usually come in complaining of pain. They're usually breathing, but it hasn't gone down, so it hurts, okay? So they might be a little bit of not swallowing all that well, all right? I mean, there's all sorts of things, any small things a kid can, go ahead and swallow. Now, what's our concern at first? Well, something's down by the airway. We always worry about airway, keeping them calm, sitting them up. And can you imagine how they take that quarter out? Because sometimes it doesn't go down and they have to remove it. Years ago, they took them to the OR and they did a bronchoscopy and they would take clips and they'd go in and clip it out. But that's an overnight stay, that's an OR visit. It's a lot of extra, isn't it? Well, today, the last one I did was a little 4-year-old boy swallowed a quarter, was sitting just like that. And the surgeon came up, and this child sat on the surgeon's lap. And we took a Foley catheter, put it down the mouth, opened that Foley balloon when it was below the coin. And I told the little boy, he's going to pull. And when you cough and that quarter comes out, whoever gets it first keeps it. So he pulls it out. The kid coughs, Foley comes out. He sort of vomits a little, spits a little bit up on the floor. The kid goes right to the floor, gets the quarter, and guess what? He forgot about being scared, didn't he? That was one of the best distractions that I have done. And yes, he did keep the quarter after I washed it. Now, pertussis. Like, why am I mentioning pertussis? Well, any sort of disease that we have immunizations for, they're always have the ability to be around because there are some children who do not get immunized for whatever reason, religious, personal, whatever it is, there are some that just don't. So pertussis is respiratory. Okay, it is requires actually zithromycin, and this is a child that it's so contagious they have to put them in one of those reverse airflows because this child could infect an entire hospital with pertussis. No, it's harder on the younger kids than it is on the older. Smoke inhalation, we see these a lot. I've seen this actually after Hurricane Andrew, where they were having a fire in the house and the smoke wasn't being vented and the whole family came in, smoke problems. And what do? You just overload them 100% oxygen. And actually, I had 2 of them go to hyperbaric treatment for smoke. Now, tobacco smoke is a big, 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 big deal on children. It affects ear infections, it affects SIDS in the infants. So it is a big problem that you shouldn't be smoking around pregnant mothers or with children. Cystic fibrosis, pretty well heavily hit on exams and on HESIs, is something that you need to understand. So what is cystic fibrosis? It's an all over the body type problem. It's lungs and it's nutrition, and it's also electrolytes escape onto your skin, specifically salt. So, cystic fibrosis, we usually today, with all those pre-testings that we do, we know that the child could have it or not, but not every person gets tested. So how would we know to even look for this on a newborn infant? Well, at birth, this is a child who will not have a bowel movement in the first 24 to 36 hours after birth. Cystic fibrosis, meconium ileus, at birth, they're not going to be moving their bowels, and we will be testing for it. You're going to learn next week, we're going to check for hypothyroidism. Same thing, no bowel movement, first, 2 days. And the third thing is something called, this is week 8, Hirschsprung's disease. 3 things that could be from not moving their bowels that we'll be testing. So, no bowel movement, we're testing for cystic fibrosis. How do we test for it? Well, it's the salt that goes on the skin that we're measuring to measure if we have cystic fibrosis. If you told that mother to lick the baby, they would taste intense salt. I mean, it's quite distinctive, the amount of salt that they lose. So, do you think we're going to be holding a salt shaker on these children? If they're losing salt through their skin all the time, do we hold the salt shaker or do we give it to them?
Give it to them.
Absolutely. Absolutely. Thank you. So, right now, as part of the diet, we're going to give salt. The other symptom is all about that lung stuff. What happens is they get mucus in their lungs and it's thick and it sticks and it can't get out. Okay. So this is a child where they breathe in an infection, it goes into this mucus. I call them petri dishes, ready to grow whatever, and infections like crazy. They are in chronic infections in their lungs, pneumonias, bronchitis. Their lungs always sound pretty wheezy, short of breath. That's normal. Now, the other part, this is the third part of the problem of cystic fibrosis, is the nutrition. They do not digest fat. They're missing an enzyme from the pancreas that helps digest fat. So, fat goes right through them. Yes, with this nutrition, we do try giving them that enzyme. Usually it's called pancreatase, is one of the names. We give it with meals right before, not an hour, not 2 hours before, not an hour after. With the meals, we give the enzyme, and that will help with some absorption of their fat. So, those stools are almost like beer foam. It's foul, greasy, foamy stool, and it stinks. They're very malodorous, okay? Now, they're losing a lot of fat. Fat is the highest of all calories of any nutrition. We have protein and carbohydrates, which are 4 calories per gram. And then you have fat, 9 calories per gram. So you've got to double the protein, double the carbohydrates in order to get those calories. So it's hard to eat that much. So it's poor growth or weight gain, even though they're eating, because they can't digest all that fat. And it's going to keep coming out. So, diagnosing it, yes, we're going to give those sweat tests and we're going to be measuring. And we don't need a number, just to know there's high level of chloride in the sweat, and that's a sweat test. What's the treatment? Antibiotics. We're also going to give them medicines to keep that mucus open. There's some that smell like rotten eggs, and it does work. All of a sudden, it loosens up and they're able to spit up large amounts of it. They're also going to be getting CPT aerosols. Now, when we're giving aerosols on these children, we should give it before we do CPTs, then do chest CPT, get rid of all the mucus, and then they can eat. If we did it after, they'd vomit all their food. So we're going to do aerosol, CPT, pancreatic medicines, and they eat, right? Now, at the end of the day, because there's so much coughing and there's so much mucus, so much possibilities of infections, make sure we clean the equipment every night. Soap and water. That's it. The mask and stuff that they're using for just CPT. Now, this pancreatic enzyme, pancreatase, is the one I call it, that helps with some absorption of it, right? So they come a couple different ways. One of them is in a capsule, and the capsule has little tiny little beads, enteric coated beads in it. Now you can open it up and sprinkle it on the food and give it with the first couple bites of it. Yes, you can. Or there's a powder. You can put powder on the food too. And then after, you eat the powder with the food, make sure you rinse your mouth. It's just like taking one of those aerosols, that Symbicort, Advair, Brio, that you have to rinse your mouth after you use it with adults. Well, same thing here, using this powder, it's going to hurt the enamel on the teeth. So make sure we rinse it also. And then the one thing I think we always forget is that we make sure the doses are adjusted. I think I see this problem with not increasing the dose of medicines a lot more actually with seizures. Children will come in with breakthrough seizures because they haven't had their medications increased in a while and they gain 10, 15 pounds, right? And that does make a difference. So again, management, respiratory, airway, bronchodilation. What sort of physical activity would be good for a child with cystic fibrosis? What do you think? What's really good for the lungs? It's my favorite.
Walking.
Running? Oh,
How about in a pool? Going underneath.
oh, okay.
You take a deep breath, go underneath. You're creating positive pressure in the lungs and you're opening them up. Actually, swimming, probably one of the best for everything. Asthma, nobody's allergic to water, right? And then you've got cystic fibrosis and you need this good lungs. And yes, now walking, yes, can be good. Yes, they need to get up and walk, but I think the best is actually swimming. But yes, type of physical activity and frequent, not just once a day or when they want to. And then how do we treat these pulmonary infections? These children are always with PICC lines, always getting IV antibiotics, or they're getting gentamicin, neomycin, tobramycin inhaled in the aerosols, and we can do it that way also. So these kids are maintenance. They take, at least morning and night, and in between aerosols. It's a lot of things for a child to do. And as a child gets older, this would be a great one to put in some sort of support group, to talk to other kids about what they're going through, especially when they get to the adolescence. So, all right, now we got the GI problems. Now we know how to take the pancreatase. We now need to know what sort of diet. Well, high protein, high calorie, high carbs, right? Are we going to give fat? No. We're going to try to decrease that as much as possible. Because of cystic fibrosis, that it does have problems with intestinal obstruction, we're going to make sure we take the medicines and we monitor that frequently. And they also do have some reflux, and just to watch that also. But cystic fibrosis, high protein, high calorie, low fat, and give them a salt shaker, please. Diabetes is a thing that can be an outcome of cystic fibrosis. Cystic fibrosis is a lack of an enzyme from the pancreas. I mean, insulin comes from the pancreas too, right? So these are children you may want to do some Dexazon, looking at blood sugars, or hemoglobin A1Cs. Are we becoming, as we get late school age into adolescence, right? We could see that. So we need to be aware of that also. Cystic fibrosis and men. Now, men also have one more thing. Women can get pregnant. It's not a problem. You have all the body parts, it all works. Yes, it's high risk, but there's no problem getting pregnant. The problem is if you're a male with cystic fibrosis, you cannot get that sperm to the woman. Something with vas deferens and mucus, and it can't. But if they do a bilateral lung transplant in 1 year, it's possible for them to father a child. So that's everything about cystic fibrosis. Sleep apnea, I think that adult, child, anybody, we all get it. I mean, I do. My husband has to beat me up some nights when I'm sleeping. So, this is a child that you would have to do a sleep study, see what's going on. If it's that obstructive thing, let's take those adenoids and tonsils out of there and then place them on that CPAP BiPAP. Because what happens? You get a child who's not sleeping, they're going to be irritable during the day, they're not going to learn, so they need proper rest. So another acute respiratory distress syndrome. So you have a child who either was overwhelming septic, was in a car accident, trauma, crushed chest, or a child who had a near drowning. So this child, let's take that near drowning because I think it describes it well. Take a child who was in the bottom of the pool. Somebody found them, got them up, got them breathing, and by the time rescue came, they're running around and everything's all right, right? No. The thing about lungs is sometimes they are not going to show the injury up to 72 hours later. So this child would have to be admitted, be placed on some sort of O2 saturation monitor to see if their O2 start to drop, okay? Because they can go respiratory collapse 3 days later. That's pretty insane, isn't it? But it's something that we know about. And that also happens with sepsis, trauma, or even drug overdoses. So respiratory distress syndrome, lung shut down, clamped off, you're not breathing, and you can't oxygenate because that water in that lungs created hypoxemia and damage of the tissues. So many of these children, and it doesn't have to be a baby, it can be even adults, are placed on something that's called ECMO. Now, I actually was ECMO certified, and I find it interesting. It looks like a heart-lung machine, but it doesn't have anything to do with delivering cardiac output or blood pressure. It only puts oxygen in the blood and returns it because the lungs can't do that. And then the lungs can be rested so that we can slowly turn off the ECMO, decrease the flow that we're giving, and then that child's lungs will be healed and then they can breathe. Sick, 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 sick child. Now, I always mention CPR because you're always going to have a CPR question. What happens if you choke? How do you take care of that? Do you know one man? Do you know two man? All of those things are important. And then what about the family members? Family members are, used to be thrown out of the room, the door was closed, and children used to die alone without their parents. And that's the way it was because they didn't want them in the room. And I never understood why, but that used to be policy. But now we highly encourage that the parent be there and watch that they know that everything possible was done, or that they could be there holding that child's hand in their last moments, or be there and they came through it. Okay, very important that we remember families. Okay, asthma. Probably the most common of all childhood illnesses, right? And we know asthma, many children do grow out of it. What's asthma? It's that bronchus that's got this hyper responsiveness. Let's say or a trigger. Maybe it's cat hair, gets in the air and gets in the lungs, and the lungs just swell up, and now air goes in and it doesn't come out. So what are you going to see? With asthma, you're going to be choking and coughing and this profuse expiratory wheeze. Why is it expiratory? Well, I said oropharyngeal stuff, croup, epiglottitis, is inspiratory stridor. But asthma, the upper airway's fine. Air gets in good. But those bronchioles all swollen in there, now the air is trapped. And now the air can't get out. If you listen to a child's lung that is in an asthma attack, you're going to hear the smallest sound of an expiratory wheeze, and it could be just a little in the end. With asthma, our goal is to prevent any sorts of exacerbations of the asthma, and trying to keep these kids as normal as we can. I mean, if you're allergic to grass, obviously you can't play sports out in the grass unless you get desensitized or have medications that's going to help you through that. Swimming is good, right? I love swimming. And maybe tennis, whatever else is there, bowling. I mean, there's all sorts of things kids can do that can be avoiding those things that cause problems. Now, that bottom box, those 1, 2, 3 little things there, they're called a spacer. Now, there's this old thing about you can't chew gum and walk. Well, many kids or adults can't push a button and inhale at the same time. So those meter dose inhalers are no good if you can't put it in your mouth, squirt it, and at the same time. So if I get a child in who's having, quote, an asthma attack, and they've taken their MDI medicines, I'm going to have them show me how they do it. Because giving an extra one, they're already distressed. They're going to get another one anyway. So please show me. Many a times you're going to find out they don't know how to push and inhale. So what am I going to do? I'm going to get them a spacer. And that's a little mask that goes around the mouth. At the end of the tube, we put in that MDI thing, push it, whatever the dose is, 1, 2 times, and hold it on their face. And then they inhale 3 times, 4 times. Infants, smaller children might cry, but guess what? They're taking deep breaths in and out, so they're getting the medicine. And eventually they'll end up like this little boy here. They're going to be doing it by themselves because it now is not threatening because they've been doing it for a long time. So just like adults, we have our rescue, we have our preventative ones, morning and night, prevents our bronchospasms. And then in case of, flares where we're having an asthma attack or our lungs are getting irritated, we can do corticosteroids on it. Now, what happens when you have asthma and you can't break it? I'll tell you a real story, and it's my husband. About 7 years ago, right before Thanksgiving, this man decided to have an asthma attack. And I couldn't manage it at home. And I've got almost everything there, and I'm pretty good at managing them. Well, I couldn't. So we sent him to the ER. Of course, I was with him. That night, about 3 in the morning, he had a severe bronchospasm and he couldn't come out of it. It was so bad, they sent him down to the ICU. He was so distressed and so restless, he couldn't sit the proper way on the bed. He wanted to sit on the end of the bed facing the wrong way. So we're like, listen, he's sitting there, he's fine, let's go. And we brought him down to the ICU. How did we get him through status asthmaticus and not get him intubated? Because I wouldn't want him intubated, and I did everything to prevent it. Well, the first thing was to calm him down. I could watch all of a sudden the heart rate go up a little bit, and I knew when it was going to be continuing. And this was every hour on the hour almost. So I would hold his hands, I'd look at his eyes, and again, calm them down. Like I said with a child, where are they the most comfortable? Where are they the most relaxed? That's where you want them to be. So status asthmaticus, we're going to put them on full support. They're going to be on racemic epi if they need it. They're going to be on aerosols, almost continuous, my husband was having. He's going to be on Solumedrol, high dose Solumedrol, and an aminophylline drip and oxygen. I mean, all of these things, this is full support. And 12 days later, he went home and has not had an asthma attack since. It was scary. Oh, guess what we get to do now, guys? Who wants to win a Kahoot? All right, Elaine. How about you, Terry? No? Maybe? Come on, smile. You have a pretty smile. Is that Taisha? Is that how you say your name? Taiza?
Taija.
Taisha. I was close. Close, but no banana, right? Here we go. Respiratory. All right, let's just go. Respiratory. A majority of upper respiratory infections are caused by what? So it is viruses. One of the names of a virus is Haemophilus influenza, but yes, it is a virus. Do you all know when we can give ourselves a flu shot to infants? How old do they have to be? Anybody know?
Um, 6 months.
It is. It's 6 months old they have to be before they can take the flu shot. Very good. Thank you. You walk into a 6-year-old's room and you find them not breathing and doesn't wake up. What are you going to do? It's amazing how much even CPR, the way we do it and the counting of it, how that's even changed in the last, since I've been certified. So number one, we do chest compressions immediately. And as we're doing that, we're calling for help. A multi. What are some signs and symptoms that smaller children may exhibit that have a respiratory infection? So, respiratory infection kids, number one, they stop eating. They might vomit once, they may or may not have a fever, and their tummies are going to hurt, and it's all of the above. Our goal is with these children, especially with fever, let's lower that fever. Let's get the fluids in them. And if all they can get is fluids, that's good. A multi. What do you look for when assessing respiratory function? What's part of your respiratory assessment? So the rate, the depth, if they're labored, if they're easy, absolutely. Children, you can actually look at them and you could tell if they are working hard at breathing. You'll see that between the clavicles, you'll see them start to pull. What would you see in an infant? Those are the ones that you look at. And if I see nasal flaring and at the end of a breath, I hear a grunt, and you see them bobbing too, right? That is a child, an infant is about ready to collapse and require more resuscitation. So yes, respiratory function, figuring it out what to look for. What would you look for after a child has a tonsillectomy? What position do you put a child in after a tonsillectomy? So our concern about a tonsillectomy because of the amount of scraping and cautery and scabs in the back of the throat is swallowing. And swallowing is telling you there's bleeding going on there. It doesn't mean they're vomiting, doesn't mean it's coming out their mouth, but you're seeing them start to swallow. If it's bleeding that much, they need to get to the doctor, and then most likely, again, it needs to go back to the OR for cautery. A multi. Nursing care for a child status post tonsillectomy include so it's not necessarily frequent pain medicines, but it's needed, but I put it as frequent, which is fine. We're not going to give spicy foods. It's going to burn like orange juice, stuff that's going to burn. We don't want to do it. Gum to help the ears pop on the older children, and an ice bag. That's for pain. Again, only the older kids are going to take it. The younger kids don't want that. A multi. What signs and symptoms would you see in a child with otitis media? Definitely ear pain. And as I've said, otitis media, priority, nursing care, medicate for pain. Okay. Your nursing diagnosis, pain. That's going to be it. Okay. We know that if they're not feeling well, they're going to lose appetite. Absolutely. And they don't have fevers usually, believe it or not, with ear infections. And if you see that oozing of purulent ear drainage, that means that ear has already popped that the middle ear, and it's going to require probably some drops to put in the ear, antibiotic drops. A multi. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? What is that called? Mm. It is called bronchitis, or tracheobronchitis is the full name of it. Asthma is not a dry, bothersome cough, and it doesn't necessarily keep awake at night. And pneumonia, again, it's not dry. There's phlegm, there's secretions, there's some consolidation. So that is a moist cough. The monthly immunization for RSV is so it's called Synagist, palivizumab. Hib is that Haemophilus influenza immunization in the beginning. Humira is for rheumatoid arthritis. And next, in the cardiac, I'm going to go into the Indocin to tell you what that is. And it's one of the names you need to know. A 4-year-old child's been taking meds for asthma, but they're still wheezing. What information is important? What do you need to know? You've got a child. He's in there. He's wheezing. He has asthma. What do you need to know? What did I tell you I need to check on that? It's, are they using it properly? Or do they need me to get a spacer? Good job. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? 8-month-old. So what are your vital signs on an 8-month-old? All right. These are the type of questions. That's why I show you what the vital signs might look. I mean, up to 1-year-old, you might see 100, 120 heart rate normal. O2 sats on a child above 92 is perfectly fine. So which one is distress, substernal retractions, and look at that restlessness. That's hypoxemia. Signs and symptoms of asthma include all except so all except a shortened expiratory phase. What should it be? Prolonged. Remember, I can get air in on asthma, but it gets stuck and it takes extra effort to get it out. So it's prolonged expiratories. Trying to get it out of the lungs. That's what my husband's son's lungs sounded like when he was in asthma. On the right bottom lobe, I heard a, and that's all I could hear. It's the only air he'd be moving. It is scary. What should you not do to children diagnosed with croup, epiglottitis, or just added TNA? What wouldn't you not do? So anything that you have inflammation in the oral pharyngeal airway, do not put anything in there and don't touch it. So leave it alone, unless you know how to intubate. Nursing interventions with a patient with epiglottitis would include, well, epiglottitis, what is your problem? Your epiglottis is covering a trachea. What's the big deal? So airway, airway, airway. This child cannot maintain their own. The epiglottis is covering the trachea. Have intubation tray or a trach tray, something airway at bedside. Which triad suspects epiglottitis? What was the big thing about epiglottitis? I told you. It's that drooling. Whenever you see drooling, they can't swallow. They can't even breathe. So they don't even swallow. So sore throat, difficulty swallowing, and that drooling. Just they can't. And that muffled frog voice is what they call it. Does anybody know what the blue one is? Polydipsia, polyphagia, polyuria. It's diabetes mellitus. It's next week. Multi. Treatment for infectious mononucleosis. Let's go on an ATV and go ride in the Everglades, right? No. Treatment, it is a viral infection. It's a Epstein-Barr herpes-like virus, no antibiotics. So antipyretics, fluids, and rest. And most important, no contact sports, protect that belly because it can burst and they can die. And it happened to me. A multi. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? So you're admitting a child to the unit, an infant. They got a fever and a cough. What do you need to know? So APGARs are not important at this point. What we need to know is number one, immunization status. I want to protect myself and the other children in the unit, right? So I need to know that they're up to date or not. And then I need to do what I need to do, whether put a mask, put them in a flow room, whatever that is. Also, in order to do nursing care, I need to know the fevers and when they gave medications so that I can continue it there. Very good. How is cystic fibrosis identified? And that could be suspected when there's no stool at birth, right? But you have no stool at birth, and what are you going to do in order to figure this out? You're going to be doing the sweat test, which is looking for the chloride in your skin. And if you licked it, I'm telling you, it is salty, salty, salty. A multi. What is included in the plan of care for a child with cystic fibrosis? This is the tricky one. So who put low sodium diet on a child who is losing salt through their skin like crazy? Remember, this child needs all the salt in the shaker and in the food. And again, it's lungs and it's also nutrition. So aggressive CPT, pancreatic enzymes with meals, high protein, high carbohydrate diet. What medication would you hold for an infant that is vomiting and vital signs are 98, 88, and 32? I want you to know all of these medications are possible for infants to have. And it's mics or milligrams per kilogram, and they work well. I've used all of them. So if you have an infant who's on digoxin and they vomit, you're going to hold the next dose. You're going to call the doctor, and you're probably going to be doing a dig level, and you're going to be doing a potassium or electrolyte level just to make sure we're okay. Sometimes it's only vomiting that you might see. Again, this had the heart rate low. That was your other sign, but vomiting. Which information is most important when rheumatic fever is suspected? What causes rheumatic fever? So rheumatic fever is caused by a strep infection that was treated not completely or not at all. And then the strep attacks the body in many different ways. I do more of it in the next part of the lecture, but it's because of the strep throat. The strep attacks the body. And the one thing about rheumatic fever is whatever symptoms all they might have, the one thing that it does attack is the mitral valve. And if they've already damaged the mitral valve, that damage, that's not reversed. But the rashes and the nodules and sore throats and all of those things all go away, but that heart valve will always be damaged. Signs of shock in children include all of the following, except you guys should understand shock and all the sort of things that you may see. So the one thing about shock, hypotension, tachycardia, poor capillary refill, decreased urinary output, altered mental status, skin tenting, dry lips, gums, all of these things are showing that the body doesn't have enough in it and, it's in shock. Hypertension, you're not going to see that in shock. We want to get the blood pressure up. Which of the following is the most common cause of shock in infants and children? Common. That's infection. Okay, the rest not as much, but all children are apt to get an infection in one way or another, and it is the most common. A multi. Signs and symptoms of rheumatic fever include so rheumatic fever. Rheumatic fever has where you have the respiratory distress, you get swollen glands, you get a rash, the subcutaneous nodules, and then there's this chorea. Chorea is movements that you can't control yourself. And usually that's what will bring the parent in, like to an emergency room, like something's going on, something's not right. Even those irregular movements, that central nervous system problem, even that is corrected when we place the child on an antibiotic for the strep. Child just had abdominal surgery and can't cough well enough to expectorate secretions. What's your priority? You want them to cough. You want them to expectorate secretions. So how are you going to do that? And how are you going to make a child do anything that's in pain? You're going to medicate them for pain. And then they'll get up, get out of bed. They'll use incentive spirometry. At that point, they'll do anything for you. But again, medicate them for pain, just like you would an adult. Do the same thing for children. They hurt just the same. An infant of 3 months has a fever of 103.6. What would you medicate the infant with? Only acetaminophen till 6 months old. At 6 months old, you can add ibuprofen. Apparently, there's something with bleeding coagulopathies with ibuprofen that the infant can't tolerate till 6 months old. So only acetaminophen. Another multi. A critically ill child is on complete bed rest. What can a nurse do to prevent complications? So, yeah, we can elevate the head of the bed if it's ordered for it. So I would give you credit for that. But again, when we're talking about a child, complete bed rest is all those preventing lungs and blood clot type things, right? Instead of spirometry. We don't want breakdown. Keep them dry, turning them side to side every 2 hours, rubbing the area with lotion to keep the skin moving, and then using pillows and blankets. I use stuffed animals and toys and beanie babies, the little ones next to little infants' heads were intubated. So if they open their eyes, they just see a cute little beanie baby, whatever squishy toy it is there. And I used to love doing that. And the parents go, oh, look, he's looking at the little teddy bear or whatever it was. How can oxygen be delivered that is easiest tolerated and accurately monitored for infants? Easiest tolerated and accurate. And the answer is an oxyhood. Now, an oxyhood is like this clear plastic. Oxygen goes in it, they monitor it, and it's very reliable. Plus, the kid can use the fingers and hands and the mouth or suck on a pacifier. Nasal cannulas, they have to tape it to the skin. So they always take their fingers and they rip it off. So they're hurting their face skin. So it's not tolerated well. Blow by tickles and it's not accurate. And an endotracheal tube, have you ever been intubated? I have. And being awake intubated, you feel like you're gagging and choking. It is not nice. So, oxyhood. A multi. What procedure are used to keep the lungs open with a child with cystic fibrosis? So deep breathing, coughing, chest CPT, exercise, ambulating more than PRN. Let's say QID, more than that. We want them to be really up and moving. And last question here, a multi. Children with cystic fibrosis require pancreatic enzymes with meals. What teaching should be done? Pancreatic enzymes, what do you need to know? So take it right before with meals, sprinkle it on if you need to, but you don't crush any of those extended beads at all. Change the dose as you need it and wash the mouth if you use the powder. Good. Number 3, TY. Good job, TY. And we got a B for 2 and number 1. Babs. Good job, Babs. We got a C and we got a Terry. All right, we're going to do the cardiac. I'm going to try to make it to a point where you can understand it. And then we got a short cahoots to follow that there. Okay, cardiac. One of the things I want you to do is go back and look at the anatomy of the heart and the way that blood flows. The one thing that I'm going to just tell you generally, heart works with blood flow. Think of it as a garden hose. If you kink it or narrow it, where do you think blood goes or doesn't go? And that is the whole thing about a heart. The left side of the heart is where the blood is by the engine pump, is pumped to the body, and there's a lot of flow on the left side of the heart. And then the blood goes all the way around the body and just enters the right side. So right side is lower flow. As we go on, you'll understand why I'm telling you that. So congenital heart defects means they're born with it. And then we have heart problems, usually viral infections, believe it or not, or even it could be like lupus attacking your own heart type autoimmune thing. But congenital is at birth. Now, I put this picture up here. It shows you your circulation, but I'm going to give you a story on one of the most important defects that you're going to be tested on this exam. And it's called a coarctation of the aorta. So if you look at that left ventricle, and off of it is the aortic arch, and think about after those little 3 vessels that go up to the head, let's say there's a kink in the hose, there's a narrowing. All the blood can't go down. It's going to be a lower flow going to the lower extremities. So you're going to feel pulses, maybe, but maybe very weak or none at all. Many of the times we get this diagnosis by there's no pulse, and then we start looking. Now, blood can't go down because there's a kink. So where does blood go? It has to go somewhere. That heart's still beating, trying to get the blood down to the toes, but there's a kink. It can't go. So what it does, it has to go back. Think about a hose. If you kink it, it could be back at the spigot where water is written out, right? So let's say it goes back into the left ventricle, fills it up. That gets full. Then it goes to the left atrium, that fills up, and then it goes back to the lungs. So coarctation of the aorta can lead to congestive failure because blood can't get down and go circling around the way that it should. Another thing, how are you going to diagnose this? And I did this one time. I remember this infant came, had no pulses in the lower extremities. And the upper extremities were bounding because all the blood is going to the upper ones, right? So what did I do? First thing, take a 4-extremity blood pressure, the upper and the lower blood pressures. Now, because no blood is getting down to the lower extremities, blood pressures are lower. But the upper extremities, there's extra blood flow. So blood flow is higher. Blood pressures are higher. Does that make sense to you? That's an important concept. These children usually, if they get home, and this is really a typical outline of this coarctation child that I had. A 3-month-old little girl came in and she was coarctation and nobody could diagnose her. And she came in, poor feeding, tachypnea, tachycardia. She was underweight. Cognitively, she wasn't there. Developmental delays, activity intolerance, all of it. So let's look at that diagnosis for a congenital heart. Inadequate oxygen perfusion leading into activity intolerance, resulting in diminished energy to breastfeed. So they're not eating, they're not gaining weight, they're not cognitively where they need to be. So you look at the kids, the color, we look at their weight. Clubbing of fingers don't happen till later on, 7, 8 years old. We're going to look at the heart. We're going to listen to, what does it sound like? Is it fast? Is it slow? Is it regular? Is it irregular? Is there a murmur going on? And then how are we going to diagnose these children? Well, initially, the first exam is going to be an echocardiogram. And in an echocardiogram, if they find anything that's not normal, they're going to be sending that child for a cardiac catheterization. And a cardiac catheterization will give the definitive diagnosis and then decide on surgery, what sort of surgery, when they need to do it. All of those things can be answered during that time. So, post-op catheterization care. Now, pre-op is not a big deal. I mean, it's just normal, like going to just a simple procedure. These are usually infants. Congenital hearts are infants, right? So usually they eat up to 2 hours prior to procedure. Now, when they do the procedure, they put a right femoral artery catheter and a right femoral vein catheter. Big catheters in there to inject dye and stuff to look at the pictures of the heart, okay? So when these children come back, those big catheters were taken out, pressure was applied, and a pressure dressing was placed on that right groin. The first thing I always check, because they were placed from the crib to the bed, they're moved down the hall, they're bouncing all over, and it could have dislodged the clot on that groin. I'm checking bleeding first because a little 8-pound baby can bleed out extremely quick from those big vessels. So the biggest risk for a cardiac cath is hemorrhage post-procedure. Oh, one of the things about cardiac cath is post-procedure. Do your vital signs, of course, checking the pulses, document what you feel or don't feel. It could be slightly decreased on the right side. That's normal. Look at the extremities. That right leg must stay straight, flat. You can't bend it. And these children are on bed rest 24 hours. And then the other thing we check is blood glucose levels. Did they get too much sugar in the cath lab, or didn't they get any? It's a telltale sign in monitoring blood sugars on these children. Congenital hearts, there's a lot of them. Major cause of death first year of life after prematurity, and VSD, a hole between the bottom chambers, is a VSD is the most common. Down's children. It's one of the first things we listen right to the chest, listen to the heart, making sure, because high incidence of congenital heart defects on Down's children. So I talked to you when I first showed you the heart about shunting. Right has low pressure, left has high pressure. So if it has high pressure, it's going to go to low pressure. So if you look at that picture, between those upper chambers, there's a hole. That could be the patent foramen ovale that's still open, or it could be an ASD. And the flow is going to go ASD or VSD. It's going to go back to the right side and go back into the lungs. So you are overflowing the lungs with extra blood. Types of blood flow, increased blood flow, I've already said, ASD, VSD. I'll talk to you a second about patent ductus arteriosus. What I want you to remember about patent ductus arteriosus, or PDA, think of it as an oxygen giver. Where we don't get oxygen, this is what we can do to give that infant oxygen, okay? Coarctation of the aorta, I've already mentioned what that is. Remember, stenosis, osis, is a narrowing, okay? And then decreased pulmonary blood flow, most common of all cyanotic and the most tested for you on your HESI and NCLEX is tetralogy of the low. And atresia, A is without, there's no opening between the right atrium and right ventricle, and that's tricuspid atresia. Now, another cyanotic is something we call transposition of the great arteries. What are the arteries of the heart? We have an aorta, we have a pulmonary artery, right? They're switched. So that means oxygen isn't going to the body. That's what this is. So this kid needs an oxygen giver, doesn't it? We need to give oxygen because they're not connected. But a patent ductus arteriosus connects the pulmonary artery to the aorta. So now we can give oxygen to the body and get it to the body until we can do surgery, pull off the top, turn it around, and put it back on. It's called an arterial switch operation. That's how an oxygen giver is given. Now, PDA, that's a good old thing I'm just talking to you about. Oxygen giver. Sometimes we don't need it and it stays open. And there's times we need it and it closes. So we can either close it or we can keep it open with medicine. So if we have a PDA open that does not need to be there, we're just putting extra flow going around, right? It doesn't need it. So you're going to hear a loud washer machine murmur. It's very distinctive. It sounds like, it's like a washer machine. It really sounds like that. The other thing you see is the blood pressure is really wide. Now, normal blood pressure on a newborn baby, 60/40. But look at that bottom number. It's 18. Now, if we close it with indomethacin, I'm going to watch that number come back up to 40. And guess what? That murmur that I heard is going to go away. Pretty cool. If I have a child that I'm giving medicine to close that PDA, I like to hear these things happening and I like to follow it. I'm a nerd. I like to see it happening. I can hear it, I can watch it, and I'm going to watch it happen. Now, what about that transposition who we just got in from transport and now it's a transposition who needs an oxygen giver continued? Well, that oxygen giver is fetal circulation. And mommy has kept that open while she was pregnant with that infant because she produces a hormone called prostaglandins. Prostaglandins, we also have a synthetic one that we can place on as a slow, continuous infusion. So what it does, it keeps that connection between the aorta and the pulmonary artery. So now we got oxygen going to that child. So it increases oxygen saturation levels and it maintains cardiac output. So 2 drugs you need to know here. Prostaglandins to keep the oxygen giver open. And indomethacin is when you don't need it anymore and it doesn't close by itself. We can watch it close by decreasing murmur and that blood pressure going back to normal. I've already gone over those things. Here, congestive hearts. How do we work with them? Nursing care. I got a kid who heart don't work and lungs are filling up with fluids. These kids are just panting and they're just really can't keep up with it. Their lungs are completely full. Many times you're going to be able to catch it before they really go into bad congestive failure. And how do we do that? And it's daily weights. Usually children who go into congestive failure have a sudden increase of weight, body weight, and that's usually how we see it. So we'll be measuring them. So how do we treat congestive failure? Well, we treat them with medicines to remove the liquid, make the heart work better, but we're also going to feed this child differently. We're going to take this child and we're going to be feeding them, smaller, more frequent meals. And because they have no energy at all, their lungs are full of fluid, they're working hard, we're going to increase calories. So they have to drink less fluid to get the same calories that they need. So we'll be monitoring daily weights. We'll be monitoring intake and output. We'll be not overtiring them by feeding them only 30 minutes, making sure that we increase the calories that they're getting what they need there. Now, digoxin, very common. We do give it. Congestive failure lowers and strengthens the force of that contraction, right? So we need to give it, and we're going to do the same things that we do for adults. Count apical for a minute, check electrolytes, check dig level, and in infants, the only thing might be a vomit, okay? So be aware of that. You're not going to see yellow spots. They're not going to tell you that. How is an infant going to tell you those things? That would be the older kid. Hypoxemia, we know that some of these children never have a normal O2 saturation. I've actually maintained newborn infants on O2 sats at 70%, and that was perfect because of their condition, okay? For whatever reason, it's like this bizarre thing, hard to describe to you, but any more oxygen, it wouldn't have been any good for them. So these children are going to have clubbing, and we'll see that later on in life. Also, cyanotic children, what does the body do to try to help? Well, if you don't have oxygen, the body says, well, if I produce some red blood cells, there's going to be some more oxygen carrying things here. So let's do that. Well, there's still no oxygen, but there's more cells. So that's polycythemia. Make sure that we do the same thing with procedures and these kids and teaching them and getting on their developmental level, teaching parents what to do, how to count, vomit, teaching them about the vomiting, all of these things, how to feed them. They're going to take them home. And I'm telling you, cardiac parents are actually the best. We did cardiac cath, endocarditis. This is where there's some sort of infection in the lining of the heart. It requires prophylaxis. And then rheumatic fever. I didn't go a lot of it before. I put it in the wrong cahoots, I guess, actually, but now you're going to see it. So rheumatic fever is that strep infection. It affects joint, skin, brain, and the skin, right? With all of the rashes and whatnot, and chorea. Now, chorea will go away, that weird movements. The only thing is that permanent valve damage. They have high cholesterol. They can have slow, fast, or irregular heartbeats. Actually, I saw one child at 18 months had a pacemaker, so they can go that small. Pulmonary artery hypertension when their lungs are damaged. Know that these children will be tired at any activity, chest pain, and short of breath. And cardiomyopathy, as I said, usually due to viruses, and usually they end up with transplants. There's so much tune-up you can do until it won't tune anymore. And then they do transplant, knowing that rejection is the largest reason for death. And then any procedure in kids. Chest tubes happens to be this one. If you do a procedure on a child, it's going to hurt them. Number one, be honest. Say, it's going to hurt, but I'm going to give you everything I can to help you, and it's going to go away really quickly. So you take vital signs, you give them their stuff for pain. They should be sitting up supine. And these children, when it's done, you know, they're going to say that burns, and they might even cry at you. You know, I worked in the adult cardiac ICU on a night shift, and every morning at 6 a.m., the surgeons came in to remove all the chest tubes. So adults have told me it burns intense, even when you give them medication, but it goes away pretty quickly. We check blood pressures earlier today. We find out younger kids have high blood pressure so we can treat and prevent, like, you know, kidney problems, right? And Kawasaki. Kawasaki is an interesting disease. It's all about multi-cutaneous or systemic vascularitis, inflammation of the vessels. And the one thing that we're concerned about is the coronary arteries and an aneurysm. What do they look like? These kids have the biggest, reddest eyes. They've got red lips, cracked strawberry tongue, swollen glands, cracked hands, palms, and soles of the feet. And it is some sort of immune something going on here. So what we do is we give IVIG, or intravenous gamma globins. And because of the itis, that inflammation of the vessels, we give, the only time ever, aspirin, high dose aspirin. Why aspirin? It thins the blood, it prevents clots. COVID, we all know about that. We've talked about shock and what it's all about. Anaphylaxis, we know giving epi and treating that quick, having these children with EpiPens when they know. Septic shock, we've talked about it and what to do. Again, is catching them early is the big thing. Toxic shock is due to tampons. This is usually your adolescence we talk about. And then I have a question about my oxygen giver. Surgical closure of that patent ductus arteriosus would result in which of the following? Oxygen giver connects pulmonary artery to the aorta. We cut it off. Blood can't go back to the lungs. All right. Who wants to win this one? Come on, Kayla, you can do it. I know you can. You too, Diana? Maybe?
These girls are quick.
Okay. It's that one. It's a lot of information in here. I think I made it as precise as I can and putting them into the cahoots so you know where these concepts are when you're going to see it. I think there's 20 questions and we're done for today. All right, we got to get going to get you out in a decent time. It's Friday, isn't it? Why would a child with tetralogy of Fallot not gain weight at a normal rate? Tetralogy of Fallot, cyanotic heart disease. It's when the pulmonary artery closes and blood can't get to the lungs. That's what tetralogy of Fallot is. So again, inadequate oxygen, which leads to decreased energy to feed, and then you're not getting nutrition and all of the other stuff happens. What is the treatment for Kawasaki disease? red eyes, red lips, systemic vascularitis, and we're worried about that aneurysm in the vessels. Aspirin and IVIG. A multi. A clinical manifestation of Kawasaki disease is, I used to like to watch to see these kids come in, and I've actually diagnosed a couple of them, and they're so difficult. Sometimes it's the very beginning and their eyes aren't completely red yet, but usually infectious disease has to come out and make these diagnoses. Now, chorea is not Kawasaki disease. That is your strep infection that you didn't treat, and it will go away once we treat it. So Kawasaki is the blistered, cracked palms, the soles, and the hands, strawberry tongue, and I've never seen eyes as red as these, and they get glowing red. Which of the following best describes the pathophysiology of Kawasaki disease? What is it about, and what are we worried about? If you think about the treatment, okay, so then that's what we're worried about, right? So it is called a multi-system vascularitis that may affect the coronary arteries. Has nothing to do with valves. It's the vessels are inflamed, and they're just worried about the fragility of the vessel and becoming that aneurysm, which could pop and they could die from ruptured aneurysm. A multi. Why do you give aspirin to a child with Kawasaki? Aspirin, what is it? It's an NSAID. NSAIDs are anti-inflammatories. It is part of it. It's not the sole purpose, but it does help. But the big thing is preventing clots and thinning blood. There is no pain with Kawasaki. It's not painful. An abnormal hole between the right and left atrium is called what? The upper chambers. In between the right and left side, there is a septum or a septal, okay? There's the upper and there's a lower. The ones between the uppers are the atrial septum, so it's an ASD or atrial septal defect. When the septum between the bottom ones, the ventricles, ventricular septal defect. What is the treatment for a tet spell? This is what happens when your tetralogy of Fallot, that pulmonary artery spasms, and blood can't get to the heart. So we need to do something quick to open up that lung for it to get blood. And what we do is we do what we call a knee chest. Now, if it's an infant, you take their knees and push them right up to their chest. Older children all of a sudden squat. I don't know why they know it, but all of a sudden they'll squat. There's not many older tetralogies, that are just running around there. They're usually fixed, but it's the knee chest or squat, something to do with changing the pressure of the abdominal cavity and chest cavity, and that's how it works. I had this happen to me one night at 5 a.m., and it is scary. They turn blue. A multi. Why is prostaglandins given to a child with transposition of the great arteries? Well, what is prostaglandins for? I told you it's a hormone, right? It's a hormone that mommy has, but at birth, if we need that oxygen giver, which we need for transposition of the cardiac, the transposition of the great arteries, right? Prostaglandins is that oxygen giver. So what does it do? It gives oxygen and it maintains cardiac output. Know that this is not an antibiotic. It's not infections. All it is a hormone that keeps this tube open, this connection, this shunt. It keeps it open. What is the purpose of giving indomethacin to a neonate with a PDA? So we had prostaglandins. I want to keep it open. I want to give an oxygen to this child. But now we got this older kid and it's still open there. And it's all of this wasting of blood going back to the heart, and we don't like that. So what it does, the indomethacin, it closes the PDA. It stops the prostaglandins from being secreted if there's any in there, and it closes the PDA. Okay? Indomethacin, prostaglandins, you need to know both of them. Transposition of the great arteries is what? What does that mean? And then you look at the question, what are great arteries? And that's your answer. To positions the pulmonary and aorta switch. Yes, good job. Yes. When measuring blood pressure on 4 extremities of a child with coarctation of the aorta, what do you expect? Remember, there's a kink in the aorta going down to the body. It's kinked. So no blood is going down there. It's going all up here. So what do you see? Blood pressure is lower down there because blood ain't getting there, and all the extra blood is up here. So we got elevated, usually about 20 points higher on the upper. Early signs of heart failure in an infant include heart failure. Heart's not beating well. Lungs are filling up with fluid. So, big thing is if you don't have oxygen, you don't have energy, you're not going to eat. And the big thing is poor feeding and sweating. They're working so hard. They're like running a marathon and they're not getting anywhere. Multi. Signs of heart failure in a 3-week-old with congenital heart disease. You're going to have questions regarding heart failure. What is it? How are you going to treat it? Heart failure. Lungs are filling up with fluid. Heart's not beating well. What are you going to see? You're going to see swelling. You're going to have weight gain. You're going to have hypotension. The heart's not beating well. And of course, your heart and lungs and trying to work harder to keep the in tachycardia. And you'd have cool extremities because blood ain't getting there. A multi. Feeding the infant with heart failure. How are you going to feed them? Remember, they're working hard. They have no energy. I think this question is the crux of cardiac, and what you have to understand is that children with heart failure have no energy, and our concern is nutrition. Because you don't have nutrition, cognitively, they're not going to be there. So we're going to have small, frequent feedings. Going to concentrate that formula, extra calories. You know, normal formula is 20 calories per ounce. So we've put it up there, right? 150%. They need to be sitting up so they can breathe easier. And of course, you're going to monitor for signs of increasing failure. And if they can't eat, it needs to have the rest of the food. You can lavage it after 30 minutes. So don't feed them more than 30 minutes. After a heart transplant, what's the leading reason children die? Heart transplant. Rejection, 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 rejection. Nursing care following a cardiac catheterization. So they went up, they stuck the catheters in that right femoral artery and vein. They took them out, put a dressing on, and sent them to you. What do you need to worry about? What do you need to think? Big time, number one, always check that dressing first. Know that we are not elevating that child, ambulating that child. They need to be on bed rest. That leg, that right leg needs to be kept straight. It can't bend. You can slowly raise the head of the bed, but not instantly. Where's the patent ductus arteriosus? Tell me to remember my oxygen giver and what does it connect? It connects the aorta, which is a big artery, right? And a pulmonary artery, oxygen giver, the lungs to the body. That's how you have to remember that. A multi. What is a sign of digitoxicity in infants? So when you're talking digitoxicity, the only thing that you may see is nausea, like that retching or vomiting. Of course, a lower heart rate is going to give you some clue. Seeing yellow spots, how many infants have told you I see yellow spots? Remember, that's older kids. It's not an infant. What are the signs and symptoms of heart failure in children? It's everything. It's fluid, the heart's not beating right, you're short of breath, you have no energy, you're not gaining weight, all of the above. Sudden weight gain. Which medication is commonly used to relieve the interfibular spasm of the TET spell? It just means and a TET spell. What do you think you can give to help relax that child, to make that pulmonary artery relax and to accept blood back up into it? Is basically what that's telling you. The big one is morphine, believe it or not. Morphine helps relax them. And then with that relaxing, sometimes that will help. They'll put them on digoxin afterwards routinely to spells, the children with tetralogy of Fallot. But morphine during a spell can help relieve it. Last question. Key to preventing post-op complications? And it's actually early ambulation, but I don't think it's wrong to say pain management because you can't ambulate if you're in pain. So, all right, I'll agree with you. All right, let's see how we did. Number 3, miracle. Good job. Number 2, Terry. Good job, Terry. Number 1, drum roll, Eli. Good job. Good job. And Diana and a big smile. All right, we made it through today. We're just a couple minutes early, but it's going to be your time. I owe you some, so you get it back. Let me see. Hold on. There we are. So I want you to know that this is a great week to start your projects. If you can, send it to me, and I'd love to be able to send it back to you at all corrected. Anybody who wants to go over exam 1, let me know. I can do that with you. And anybody who wants to start studying for exam 2 to get, ahead so that you're not falling behind, because it's going to get pretty rough by exam 3 with all the courses. So you don't want to get into exam 2 and, be struggling. So if you need help, you let me know. I'm here to help you. Good night, guys.